Good evening, everyone, and thank you to COS and to Dr. Chintan in particular for giving me this opportunity. And in stark contrast to the great case presented by Dr. Sabina, my case is going to be routine, not even one-fourth as interesting, and just 4 slides. And maybe we can have a big discussion after that. Um, so here goes. It was basically a 28-year-old male who presented in June of 2018 with complaints of sudden painless vision loss in his right eye, which was of 20-day duration. And there was no history of any ocular trauma or any systemic illness. The visual acuity at presentation to us in the right eye was hand motions with an accurate projection of rays in all 4 quadrants. The left eye was fine. The anterior segment examination was normal in both eyes. There was no neovascularization of the iris or elsewhere, and the pupillary reactions were also okay. There was no semblance of an afferent pupillary defect. The fundus examination, where the crux of this presentation lies, actually had dense vitreous hemorrhage in the right eye. Media clarity was grade 4, red glow. The left eye was absolutely normal. Again, there was no issue of trauma, no systemic illness. And once you see a young patient with that what seems like, at least on the outset, and a cursory history taking very dense unilateral vitreous hemorrhage, you want to rule out certain things. So excessive coughing, constipation, these particular targeted pointed questions were asked, and they were all negative. These 3 investigations this person was carrying with him when he came to us. So he had a absolutely non-reactive 0.012. The TPHA and the HIV were again negative. Chest X-ray was normal. So, as is the dictum, when you can't see the retina, you need an imaging modality to look at what's happening at the back of the eye. So that's the right eye, ultrasound. You can see that there is no PVD, the retina is on, and just anterior to the optic disc, as is highlighted by that, red arrow. It looked like a flat peripapillary oblique macular FVP because, the vertical and horizontal axial scans, we were able to make out that this kind of flattish hyperechoic sheet kind of extended all over the disc and also over the macula. And you could see that there was hemorrhage, right above it. So keeping all of these things in mind, these were the clinical differential diagnosis at this point in time. A vasculitic VH, which is, vitreous hemorrhage, was the first differential. Although, my targeted questions regarding coughing, straining, constipation, any other, the time duration when the vision loss occurred, it wasn't like he was in a gym or, he was doing some of these pranayams or yogas in which the intrathoracic pressure goes up. But still, I mean, you can never rule out a Valsalva related vitreous hemorrhage. That was the second DD. And again, no history of trauma, but young active individuals, the traumatic vitreous hemorrhage is something you must keep in mind. So these were the differentials, and keeping in mind the density of the hemorrhage and the fact that what I thought on USG was a flat FVP happening. I subjected the patient to a 25 gauge PPV, I had a video, but again, I don't think the forum for it. So just we'll get down to the crux of it. So intraoperatively, there was no PVD. There was pretty dense red vitreous hemorrhage, and there was a flat FVP, which kind of confirmed our preoperative ultrasonographic findings over the posterior pole, and there was a occluded there were multiple occluded infratemporal retinal venules, multiple NVEs in that quadrant, and thus confirmed the diagnosis of occlusive vasculitis. So this is my second last slide. So the patient actually, this is 6 weeks post PPV. The patient had an acuity of 6/18. You can see the right eye has a little bit of a temporal disc pallor. You can see that there's a little bit of a temporal disc pallor. There's also, you can see those pigmented laser scars just, adjacent to the infratemporal arcade. And there are also those occluded vessels which can be seen. The foveal contour is fairly normal. Although there are a few microcystoid changes just temporal to the fovea, and just temporal to the fovea, and there's a semblance of maybe a hyaloid remnant or early ERM formation there. And so, we subjected this patient also underwent angiogram at that point in time. The left eye was unremarkable. The right eye also, I've just put the posterior pole photos, but even the periphery, there was no evidence of any activity, no other area, capillary non-perfusion area. no NVEs to note of, and there was just some staining of the perifoveal kind of the capillary bed in the late phase, and that was pretty much it. And maybe a little bit of that those microcystoid changes temporal to the fovea. Maybe we can correlate them a little bit with whatever seen there, but essentially no signs of activity. And the patient was just treated with, at this point in time, after 6 weeks, just with topical non-steroidal anti-inflammatories for the microcystoid edema, and has continued to do fine. Thank you.